Dear Lord, we praise you, we love you. We are your children, we are your servants. We thank you for calling us to this most important job of being in pro-life and trying to change our culture. We count on your power and your authority to do that job, Lord. And most of all, we count on your inspiration. And we pray for Betty. Thank you, Lord, for today. Thank you for Betty and her wonderful, wonderful spirituality and her wonderful insights. Praise you and we love you, Lord. Amen.
Amen. So I did do a prayer. I prepared a prayer on the topic of morality or mortality, rather, since that's the topic of concern. And so I'll also offer this prayer. Lord, we ask that you bless our meeting today and grant that it be fruitful and pleasing to you. Deliver us, we beseech thee, O Lord, from a sudden and unprovided for death. Lord, you have doomed all men to die, but have concealed from all the hour of their death. Grant that Betty's presentation here today may help us all prepare for our death, and that we may pass all our days in the practice of holiness and justice, and that we may deserve to quit this world in the peace of a good conscience and in the embraces of your love. We ask all of this through Christ our Lord, who lives and reigns forever. Amen. And now we'll turn to our presentation, which is going to be given by Betty Odello, who's here with us. Betty is a RN and has a master's of nursing. She obtained her RN from Creighton University and did her graduate work at UCLA. She has worked in nursing for over 40 years as a staff nurse, director of nursing, and professor of nursing. She's also taught philosophy at Pierce Community College with an emphasis on bioethics. Betty works with the Archdiocese of Los Angeles' Office of Life, Justice, and Peace, giving presentations on end-of-life decision-making, and is part of the Caring of the Whole Person initiative. She is also the president of Scholl Institute of Bioethics, which is a branch of International Life Services, and she's one of our best and most popular speakers. So with that, I'll turn it over to you, Betty.
Thank you. I appreciate that nice introduction, Dan. And I want to thank everybody for being here with me today. It's an honor to be here, to be asked to be part of this ILS webinar. And so I thank you. And I think now what I'll do is I'll go ahead and start sharing my screen so I can get started because we have limited time. Okay. I had this already, but of course it never works the way you want it to when you're starting on here. So anyway, I think you know that this is what we're talking about today. And we all know that we're going to die. There's no doubt about it, that we all know that we're going to die and it's going to happen, but we don't like to think about it. It's not the way we like to communicate. And so we need to talk about it today, I think. So no matter how I graph it, we all are going to die someday, someplace, but we know not where or how. So human mortality is a fact, but COVID-19 has made us more aware of the mortality and that we all have limited time on this earth. Are you and your loved ones prepared? I've run into so many people that say, yes, it's a good idea, but no, they haven't done it. So today it's kind of going to be in your face, and we'll hope that it all goes well. COVID has made a lot of changes in the way we look at death, and certainly in the way that the dying are treated. I do have choices, but some of our choices are now limited. We know that we have to wear our mask, we have to do our hand washing, we're supposed to stay home as much as possible, use the sanitizers when we can. But this is the saddest part to me at all, is that if you go into the hospital and you have COVID, that in the intensive care unit, you are alone. They usually don't let anybody else come in. Maybe they'll let one person in for a little bit. But before, when I used to give this talk, I was always saying, don't leave your loved ones alone. Just let them know that they're loved. Let them know that they're cared. Hold their hand, be there with them. And of course, because of COVID, that's not possible anymore. But there's a light at the end of the tunnel. Many of us are getting vaccinated now, and hopefully that this will help. But not everybody is dying of COVID. We still have other people that are dying of other things and natural reasons. And therefore, you do have choices in this. Sometimes people don't want to be hospitalized now. And sometimes people just don't even go to the doctor because they're afraid of getting COVID. But we do see people dying, and they can choose sometimes to stay at home, to be close to their family, or if they do choose to go to a hospital, there's still limitations on visitors and how many people can be with them. According to the LA Archdiocese, if we look at the goal of good care, care is for the whole person. It involves ensuring that they have food and drink, comfort and respect, warmth and security, and accompaniment to the end of their life, so that they feel valued, that they feel empowered and loved. It's so important that we all feel that we're valued and loved. Now, choices that you will have still that we need to think about are a lot of terms here that I'm going to be discussing today. But sometimes it's confusing for people to know the difference between hospice, palliative care, the types of sedation, either palliative or terminal. And people frequently mix up food and hydration, the necessity of giving that, with withholding and withdrawing treatment. So we're going to be discussing that. There are advanced healthcare directives that I'm going to push. There are other end-of-life things that are out there that are not advanced healthcare directives, and that is pulsed, do not resuscitate. And then the thing I really want to emphasize also is because things like physician-assisted suicide and euthanasia are indeed legal, that doesn't necessarily make them right. Dame Cicely Saunders was the one that formulated hospice in 1967. Excuse me. And her goal was to take care of the person, to be supportive of them for the dying patient, not only to ease the pain and suffering of the patient, but also of the family, and to help them deal with the trials that they face. Very loving philosophy. Hospice for her is about life, not death, valuing each moment, each particle of life. Hospice we think of now is kind of like, oh, they're dying. That's not the way it was started. She wanted us to enjoy life every minute, way down to the last. Hospice under Medicare means that you have to be declared terminal within 6 months, and it can be up to a year. But you and I both know that when somebody says you're going to die within 6 months, we all know people that live for 5 years after that. And so this is not necessarily what's going to happen. God knows, but we don't necessarily know. You usually forego curative care. Hospice is always optional. You can move in and out of service, such as if they gave you a 6-month and then you got cured. You can choose your own hospice. That is true to a limited degree, because if you go into a hospital, they usually have a contract with a hospice. And so in that case, you can't choose. But if you're at home, yes, you may choose your own. Assessing hospice care is pretty easy. It's usually referred by the doctor, but anybody can make a referral. Medicare Part A will pay, as will Medi-Cal and HMOs, but you must be willing to change the focus from curing to caring. There's been changes in hospice lately. Many hospices are now for profit. When Cicely started the hospice movement in the 60s, The hospices were volunteers, mostly. A lot of religious organizations, certainly Catholics had hospices too. I used to teach with some of those, and they were wonderful, wonderful. But much of the culture of death has now influenced the hospice area, and that's kind of scary. So you'll see things like withholding food and fluid with the intent to die, sedating to cause death. Grandma Jenny, oh yeah, I wanted to give you an example of Grandma Jenny. She wasn't really my grandma, she was my husband's mother. And she was in assisted living, and she was very happy there because they had so many activities and she was always involved in something. Eventually, she was diagnosed with pancreatic cancer. And this was okay, but they convinced us, they said, oh, we'd like to start her on hospice. And in my head, hospice meant that, oh, she'll get a lot of good care. They'll give her love and nurturing and all of this. And so I used to go by every day before I went to work and talk to Jenny. But I thought, oh, well, she's in hospice. I didn't go for, I don't know if it was 2 days or 3 days. But anyway, then when I did go and I went in and I said, well, hi, Jenny. She was sitting in a chair, which was good. But she looked up, and she'd go, and she'd look up. I'm not even sure she knew me. She was so sedated. It just scared me. So I went out to the nurse's station. I said, what's up? What's up with Grandma Jenny? I said, what are you doing to her? And they said, well, we're controlling her pain. I said, what are you controlling her pain with? Well, they were giving her morphine. I said, I've been controlling her pain. She has this cat, and she puts this cat right on her side. And I think it's the heat or something that gave her comfort. Also the love of the cat, I'm sure. Once in a while, I'd had to give her Tylenol, but never morphine. And they informed me that this is the way they do it. This is the way they take care of these hospice patients, and they got to keep them comfortable. So after a little discussion, and I saw they weren't going to change, I said, okay, I don't think Grandma Jenny needs morphine. So if you insist upon doing this, then I'm insisting that we're going to move her. Well, they didn't want me to move her. She was a private patient. And so they agreed that they would not give her morphine. I was there every day, needless to say, after that. But it took 2 or 3 days for her to wake up before all that morphine left her head. And she lived for a couple of months after that. And just 2 days before she died, she had gone over in a wheelchair to, I don't know, Bonds or CVS or someplace. She just wanted to look around. 2 days before she died, she never did really need morphine. Now, a lot of people do, but not to sedate them. You need to carefully choose your hospice. And that's not always easy. We do have on the Scholl Institute of Bioethics, and you can get that either through ILS website or ours. We have questions, 22 questions, as far as how to evaluate a hospice. Some people ask me, why can't you tell us which hospices are good? The reason we can't do that is because you change administrators and the philosophy can change. Pope Benedict XVI in 2010, with his address to the Pontifical Academy, stated, under traditional medical ethics, the guiding principle is to do no harm. But contemporary bioethics abandons this in an effort to find the utilitarian goal of the greatest good for the greatest number. Under these principles, preserving the life of the human patient is not considered paramount. Very, very true. An utilitarian goal of the greatest good for the greatest number of people can include cost, ICU beds, care, lots of things. So there's been a lot of changes in hospice. Many hospices are now for profit. And that's because of the way they're paid. I'm not sure if you're aware of that or not. But when a person goes into hospice, they're paid, the hospice group is paid for giving the care. And they're paid the same amount whether when you first come into hospice or when you are closer to death. Well, as one proceeds in this cycle, as we get closer, we need more care. And so that's when it's not so profitable for hospice. So we see the culture of death sneaking in through the back door. And that's where we see the withholding of food and fluid. So you need to do it very carefully. This is kind of an awful slide, I'm afraid, but it expresses my concern. It's the invisible Holocaust. There are very good hospices out there, very, very good. This is not universal, but just be careful and choose wisely. Palliative care is a field of medicine which aims to help manage pain and symptoms for persons facing a serious illness at any stage of life. It doesn't have to be the last 6 months. It can be very early in life. It provides comfort care to relieve physical and emotional pain. Palliative care, the goal is to keep the patient comfortable. That's the way hospice started out too. May give treatment if warranted. You don't have to have that change from curing to caring. You still can give treatment. Hospitals have palliative care teams. You can have hospice and palliative both. But again, I'd like to warn you that palliative care, when it started out, it was absolutely wonderful. And I was involved in several consultations with palliative care teams and was very happy with the care that they gave the patients that were in palliative care. However, I got a rude awakening when I participated in one, and it actually encouraged the family to go into palliative care. Well, and so I was there at the meeting, and because palliative care teams usually involve doctors, they have the social workers, they might have the pharmacists, certainly social worker, nurses, but and so it's a total team approach. But the last consultation I did, indeed, I found that when the family called me the next day, they said all that team wanted to do was to take all the medicine away from my dad. And so that wasn't very good. So you have to be very careful. And as I've been on different bioethics committees, I find that the philosophy varies again. So you have to be careful. Now, if we use sedation, there is a time for palliative sedation. If people have a drastic heart attack, maybe a head injury, maybe even GI problems, that we need to give them sedation to put them into an induced coma because we want to have that body part rest. But there's no intention of dying or killing anybody. But this is just to let it rest, and then we'll take them out. We'll bring them back in a little bit. But terminal sedation is a totally different thing. What it is it's steadily increasing doses, not for the relief of symptoms, but increasing unconsciousness. Way back in the 1990s, I was teaching hospital administrators, nursing hospital administrators. Anyway, and at that time, even in the 90s, they were giving orders by doctors to state, increase the morphine 5 milligrams every hour. It didn't stay to satisfy their pain. It just said, do this. You know what they were thinking. Death is basically the ultimate goal. Terminal sedation is never acceptable because it doesn't respect the dignity of the human being, that we're made in the image and likeness of God. Okay, so enough about that. But food and hydration can be very confusing. Food and nutrition is basic care. It's not medical to give somebody food and water. We're not under medical treatment here at home. It's not extraordinary, even if it's artificial. Look at all the artificial crap that we eat and drink. Some people say even baby formula is artificial. So we have to be careful how we term these things. Food and hydration is absolutely required unless death is imminent or it's too burdensome. And I will go over that. There's 3 confusing scenarios. PVS, or persistent vegetative state. I'm sorry, I disagree with those terms. A person is a human person, and we're not in a vegetative state. We don't, just because we lose consciousness doesn't mean that we become a vegetable. So a permanent vegetative state, and it's not always permanent. One of the conferences that we did a few years ago was Scholl. Indeed, one of our main speakers was a young lady that was in a permanent vegetative state, they claimed. And after a couple of weeks, they wanted to take her organs. So the doctors were in there and talking about what a great thing this would be is if she would donate her organs. But for some reason, the husband was there and he would not allow it to happen. Well, within a couple of weeks, she came to. She wasn't in a permanent vegetative state. She was in a locked-in state. So she could hear everything that was going on, but she couldn't move. She couldn't blink her eyes. She couldn't do anything. So there are those times when people are claimed to be in PVS and they're not. And actually, one of my kids, her soccer coach was indeed claimed to be in a permanent vegetative state, and the wife wouldn't do it. And now he was coaching my kid soccer. So we have to be careful. Doesn't happen very often, but it does happen. Imminent death. If somebody is dying, they are dying. And so food and fluid is not always necessary. And I'll talk about that a little bit later. But a new thing that's on the market now is willful starvation and hydration. And they do this through and give a sedation at the same time. Some people where it's not legal to have physician-assisted suicide, they will starve themselves to death, and they think it's an easy death. It's not. It's not an easy death. Food and fluid, as I mentioned before, are basic care, and we should keep it going until their death is imminent. Now, withholding and withdrawing is a totally different scene. It's not the same as food and hydration. Okay, food and hydration, as I mentioned, as long as the person isn't dying, then indeed it's good. Now, if you're dying, again, sometimes your organs are shutting, well, they are when you're dying. Your organs are shutting down, of course, but even food and fluid can be more of a burden than a benefit. Because if you're giving them, say, food through an NG tube or a gastrostomy tube, if the body can't absorb it at all, it just goes right through it with the acid and all that goes through. And of course, then you get bed sores, the person's very uncomfortable, they get cramps. And so when they're dying, they can't absorb the food. But withholding and withdrawing, what I'm talking about is something totally different. It's not the same as physician-assisted suicide, where we choose to kill ourselves, or different than euthanasia, where somebody else kills us. The burden of the treatment outweighs the benefit of the treatment. The burden of the treatment outweighs the benefit of the treatment. Let me tell you, I know this patient that had cancer. It was actually breast cancer. And she had gone through chemo. I don't know whether it was 2 or 3 times. And she had a horrible time with the chemo. She became unconscious. She was retching. She had to be bedridden. I mean, she just had a really bad time with the chemo. So she was in recession. So then when it came back again, the doctor wanted her to do chemo again. And at this particular point in time, she said, why? What do I get out of it? What benefit is there for me? And he said, I can't say for sure, but I think you'll probably live a couple of weeks, maybe 3, longer with it. Well, she decided that she would rather enjoy her family and be home with them and not be nauseated and retching and vomiting and all those things, because the benefit wasn't worth the burden for her. And that is totally okay. I mean, there's a Vatican document that was written in 1980. That's not just yesterday, 1980. It was on that. And it says then that you can withhold and withdraw treatment. That can be medicine or surgery or chemo or whatever, as long as the benefit doesn't outweigh the burden. And that can include the whole patient. I mean, it can include social, physical, psychological, the whole business. And that Vatican document on euthanasia, like I said, it was written a long time ago, and it's still a very good document. But the issue is, how will my doctor know my plan if I can't communicate? Say I'm in a coma, say I've been in an accident, say whatever, but I'm not able to communicate. This is where you have to protect yourself and your loved ones. And that's where we have advanced healthcare directives. Now, they can be confusing. There's so many different terminology for advanced healthcare directives, and we're going to go into some of those. But first, why do you need one? Well, it respects your autonomy. You get to choose. You get to choose what you want. It has the freedom from giving the burden to the family. If you haven't talked to your family, then the burden of them making the decision, trying to figure out what you want, it's a burden. And many families have this guilt that, is this what they really wanted? Should I have done the surgery? Should I have not done the treatment? Should I have just not done whatever? You see, if you haven't talked to somebody about it, then they get this burden and they have this guilt. The advance directive respects your values, your beliefs, and your wishes, nobody else's. And the way it does that, because if you have an advanced healthcare directive, then indeed you explain what your values are. This happened to me so many times in my 40 years that you come up to somebody and you say, what's his position on resuscitation or on advanced surgery or chemo? Well, we don't know. We never had that conversation. Don't let that happen to you. It's a horrible thing. But we don't face the reality of our death alone. We don't like to talk about it. I'm sorry. It's not something that we can talk about like the Super Bowl coming up, okay? No, but you need to help yourself and others prepare for the inevitable by talking about it and completing an advanced healthcare directive. In the advanced healthcare directive, you appoint someone that you have talked to that shares your values and that you can talk to them about what it is you want. You don't want a checklist that says, I don't want extraordinary care. I don't want a respirator or something like that. And I'll talk about that a little bit more. But you need to talk about it, and we need to be there when we're talking about it. You need to listen and just talk to the other one. I know it's hard, but do it. Who needs an advanced directive? Everybody over the age of 18 should have an advanced directive. It's not just old people that are dying of COVID. It's not just seniors that are dying in accidents, in car accidents. It's not just seniors that are dying, or it's not just terminally ill people. How many young people do we know have succumbed to even COVID this day and age? Okay, I'm going to go over the different kinds of advanced directives here, and then we're going to talk about other choices that are not, and that would be pulsed and do not resuscitate. Okay, so advanced directives. The first thing is a living will. The living will became popular late 60s, 70s, when Medicare started paying for all this treatment. And actually, it was so exciting because we were getting new machines. We were getting dialysis machines. We were getting ICUs, actually. We were just starting intensive care units. And so there was so much hope and hype in trying to do what was good for people. But it became that people weren't afraid of death as much as they were afraid of dying. That first picture I showed you way at the beginning with all those tubes, people didn't want that. So like Ann Landers, now I'm looking at you, some of you don't even know who Ann Landers was, but she was very popular in the 70s or 80s. Everybody read Ann Landers. And she was saying that all you have to do so that doesn't happen is to get this piece of paper, and it's a living will, and it says, I do not want any extraordinary treatment if I'm terminal. Well, as a director of nurses, I get this piece of paper. They say they don't want anything extraordinary if they're terminal. I got news for you, as I had for them. We're all terminal. From the time we were born, we were terminal. So when you say, if I'm terminal, that doesn't mean a whole lot. I want no extraordinary care. Well, what is extraordinary to you? Is surgery extraordinary? Is chemo extraordinary? What's extraordinary? You see, extraordinary is a very vague term. So you don't see living wills too much nowadays, but you do see some. Oh, by the way, a lot of people will write that in on their trust too, that I don't want anything extraordinary if I'm terminal. Like I said, power of attorney is usually on finances, and most people have that, but it doesn't carry on after you're dying. But the thing I want to talk about more is the durable power of attorney for healthcare. The durable power of attorney for healthcare is, again, like I said, you talk to somebody that you know shares your values, and then you talk about different situations. You know, we don't have a crystal ball. God didn't tell us how we're going to die, what our situation is going to be. Thank goodness we don't know. But anyway, the issue is that we don't have a crystal ball. So to say, I don't want a respirator, well, we use a respirator in surgery now. We use respirators to keep people quiet for a while so that their body can recover. So everything can be said like that. So doing a checklist just doesn't work. talking to somebody, sharing your desires and your wills really does. Okay, they only are effective when a person becomes incapacitated or unwilling to make the decision for themselves. You don't need an attorney or notary required. There are a few exceptions, especially if you're going to benefit from the finances. But usually you can just have 2 witnesses to your signature, and that's all it takes. It's generally honored by courts and hospitals, can't always. Can be very complete and comprehensive. Let me just go back to that, why it isn't always honored by courts and hospitals. Well, one case I was at, actually I was working in surgery at the time, and a young anesthesiologist, he had an arrest. He arrested right there, a young guy. And he was in intensive care. And his partner came in with, I have the advance directive. He doesn't want anything. He doesn't want anything. He doesn't want anything. And he was a young man. We had no idea what was wrong with him. And so we then decided, the doctors and the administration decided to override that. And of course, he walked out of the hospital within a month, and he's back working very soon. So there are times that the hospital and administration will decide to overrule the advanced healthcare directive. They can be very complete and comprehensive, but avoid specific details until the time of need, like I've mentioned before. And if you've been asked to be an attorney, in fact, or the one that makes the decision for somebody else, if you do not agree with their wishes, I would not agree to be their attorney, in fact. And indeed, I've had to turn people down because it would be hard for me to follow what they wanted when I didn't agree with it. So make sure that the person you get to decide with your wishes, that they agree with your wishes. Now, there are some people that I probably would not want to choose as my attorney, in fact. Number one, maybe my own husband, because he might want to keep me alive no matter what. And that might not be exactly right. But let me tell you other things that I've heard. When I was in an intensive care unit, I heard people arguing, you've got to keep the treatment going. You've got to keep the treatment going. And we said, why? Well, we need their Social Security check. Can you believe that? Yes, I've heard that. I've also heard in intensive care units that indeed, we really want to keep this going. I think that there's a lot of hope in this patient. Why do you want us to discontinue all treatment now? Well, we need the money for the kids' college. It's just crazy things. Like I said, get somebody that agrees with you and your values. Now, POLST is a physician's orders for life-saving treatment. And I'm going to talk about that in DNR in just a minute. It can be called a POLST, or it could be MOLST, a medical order for life-sustaining treatment. And when it was developed, it was wonderful, the philosophy, the care for it. And it became very popular. The reason that some of these advanced directives, I have a stack of advanced directives like this, but some of them are 25, 30 pages. Well, if I'm a nurse coming on duty and somebody arrests and I haven't even gotten a report on them, how do I know? I don't have time to go through a 25-page document. So they developed this POLST. It's a bright pink document, and it's got the checklist. I want everything, all life-sustaining treatment. I do want to be resuscitated. I want artificial nutrition. And it's very easy to see. So the goal was very good. Okay, the goal was very good. However, though it can't be legally required, and so I used to tell people, just don't sign it, because check boxes, I don't have time for check boxes. I like something that's more general, just because we don't have that crystal ball. It can't be legally required, but nowadays what's happening is that if you want to go into this assisted living, or if you want to go into this hospital, they might require that you sign this POLST. Okay, so if they require that, and there's not another alternative, I'll show you what you do with that POLST in a minute, because it has a full force of a doctor's order. So as soon as it's signed, it's a doctor's order. It is not an advanced healthcare directive. It must be followed under all circumstances, immediately actionable. Whether, even if you're alert and say, hey, I've changed my mind. I want to be treated now. I want to be treated now. Well, your POLST says you don't. So that's what we go by. and it can be signed by someone who does not know you. And the way this happens is that they have, if you don't have a pulse, they'll send somebody out that they've trained to get these pulse figured out. And some people, when they get the person that's coming up to help them sign this pulse, they might be biased towards not having treatment. Just say, like, do you really want to be resuscitated? We can break your ribs. They're going to put a tube in you. You won't be able to talk. You won't be able to eat. Nobody really wants this. So you don't want to be resuscitated, do you? Just the way it's stated. No, I wouldn't want that at all. Okay, then they come up and they have the pulse signed. It's not signed. It's filled in. And then it can be signed by somebody that maybe not even ever saw you. And it can be signed by not only a doctor, but a nurse practitioner or a physician's assistant as well. It's a check format with bias, as I mentioned. And it's opposed by the United States Catholic Conference of Bishops, by the National Center for Bioethics Control, and it's also by the Catholic Medical Association. It's usually bright pink, but it doesn't show up on the slide real well. So what I would tell you to do is to say you want to attempt resuscitation, you want full treatment, you want artificially administered nutrition. And the reason I say I want you to do that is because in D, what you do, you say, I have an advance directive, and this is the person that you need to call. It's got the name and the phone number. Because if indeed you are dying, and all of these things probably should not be done, absolutely should not be done in some cases, then they should call you. And then you can override this because you already know, because you are the attorney, in fact, the person that's making decisions for this person. And so that way we know that their wishes, my wishes, are going to be done. And so it works good. Even though they say this is voluntary, like I mentioned, it's in the back part of the pulse. Nowadays, people are getting around that by saying in order to be admitted. But it's very worthwhile to be reading it, but do say you want everything. And if you have questions about this, I hope you're jotting down some notes so that you don't forget them. So there's good things about the pulse. It's a simple checklist, but a simple checklist is the worst thing because we don't have that crystal ball. It's voluntary, but not always. It's signed by the medical personnel, PA, physician assistant, nurse practitioner. Doctor signing it may never have seen you. This happened to a friend of mine. Anyway, I haven't got time for a lot more stories. Okay, doctor's orders, it must be followed under any circumstances. And now what we do know, it overrides the durable power of attorney for healthcare because it is a doctor's order. And some places they're using electronic registry. Again, it's a great idea. It's right on the computer because now all the charting, everything is done on the computer. I love the electronic register. Yeah, I did. Not anymore. On a bioethics committee that I was on, there was this lady in here in the hospital, and she was on her way out, everybody thought, but she eventually walked out. Well, so she had on the electronic registry that she didn't want anything. Well, she comes back into the hospital, I don't know, 6 months, a year later, and she had changed her pulse. Well, it never got changed on the registry. It was not a good scene. It was a terrible situation. Okay, do not resuscitate. That's another doctor's order. It is not an ad directive. Okay, if you agree to have a do not resuscitate order put on the chart, that also must be followed. You cannot resuscitate this person. I think I've gone through this. It must be followed. There is a time and a place for this order. People say, oh, what do you want to do? Just prolong the dying process? Absolutely not. Absolutely not. But God made us in his image and likeness. We have the dignity because God so made us that way that we have to use that life for him as long as possible. But then God doesn't want us to just prolong dying. No, we are so fortunate that we know that this isn't the end. This isn't the end. If you're sitting with dying people, oh, I could tell you stories about what happens if a person has faith and what happens if they don't have that faith. It's just such a difference. But there is a time and a place for this order. If somebody is dying, let them die. You don't have to prolong it. Nobody says that. Again, but you need to talk to the people so you know what's happening. Other choices you have, you need to think about organ donation, and that's another whole story I could get into. But anyway, organ donation it's very imperative that you make your choice about that and let that person know what you want. What about my remains? Do I want to be buried or do I want to be cremated? A quick story though, I'm Mary. Mary is a fellow professor of mine, and she had breast cancer, and she was in remission a couple of times, and one time quite a while, but then she went back and got it again, and then she was dying, and it was I don't know, I think it was 3 or 4 years that she suffered with this last bout. And after she died, the husband called another professor friend of mine because he didn't know what to do. He said, what do I do now? Where do I take her? What happens? And he said, well, what did Mary want? Where did she want to go? Did she want to be cremated? Did she want to be buried or what? He said, well, we didn't talk about that. We never talked about those questions. They had no family here, no kids. They just had one another. And it was a beautiful relationship, but they never talked about that. So I went to her funeral, a beautiful Catholic funeral, and then went to the gravesite. But the gravesite, it was a nice gravesite. I can't say anything wrong about the gravesite, but it wasn't a Catholic one. And I was just kind of surprised because I knew Mary is just so very, very Catholic, as is her husband. It was, I don't know, probably a month later, I was talking to my other friend that was her husband's friend. And I said, Richard, why did you not have her buried in a Catholic cemetery? I said, I don't mind. The cemetery you had her was fine, but I'm just wondering why she wasn't buried in a Catholic cemetery. And he looked at me and he says, do they have those things? Do they have Catholic cemeteries? Of course, now you and I know that. But if somebody would have gotten an advance directive, Mary might have been able to say that. Now, I don't know whether she wanted it or she didn't. I just thought it was interesting. And I was amazed that this day and age, somebody didn't know there was such a thing as Catholic cemeteries. But if you don't tell somebody what you want, how do they know it? Got to be there, got to talk to them. Now, these are choices that you have, as I mentioned earlier. These are legal things, but they're not morally acceptable. Okay, physician-assisted suicide is now legal in California, June 9th, 2016. Dan, that just introduced us, was just telling us now about another appeal that they're working on. God bless him, about this law. It is seen as an easy way out, or as a death with dignity, as we say. There is now pressure from insurance companies. I mentioned this at a meeting yesterday, and people didn't hardly believe it, but there are insurance companies that say that, no, we can't pay for your treatment, but we will pay for your suicide pills. And by the way, the cost of those pills are going up statistically, horrendously. But physician-assisted suicide doesn't respect the human dignity, that we are made in the image and likeness of God. And God gave us life, and God will take it away. I ask you to find out if your provider does physician-assisted suicide. And if they do physician-assisted suicide, I might recommend you get a new provider. Here we see 9 states and DC have it now legal, but this is a chart that's scary to me. Look at all those beige areas. That's where they're talking about making it legal now. All those states, oh, scary. Well, this is how our health plan pays only for physician-assisted suicide. These laws are passed because they say that people don't want to die in pain. And I agree. Nobody wants to die in horrible pain. Medicine has come so far that, people understand now you don't have to die in pain. Look at the reasons people ask for physician-assisted suicide. Because I can't do what I used to do. I can't play tennis. I might not be able to go skiing. Loss of autonomy. I can't choose for myself. I don't want to be a burden to others. And I don't want to lose my dignity. I don't maybe ever want to wear a diaper or whatever. These are the common reasons people ask for physician-assisted suicide. I don't see pain up there. 82% of people say it's important to put their wishes in writing. 23% have done it. Have you? Euthanasia is intentionally choosing to end one's life, never acceptable. This is what I've talked about. I'm running out of time. The bottom line is we don't easily face the reality of our death alone. Help yourself and others prepare by talking about it and completing an advanced healthcare directive. We need one another. You got to be there for them. But to be there, you have to take care of yourself. And in this COVID time, wear your mask, stay 6 feet apart, wash your hands, use sanitizer, stay home. And of course, I got the vaccine and I was so thrilled to give it. Okay, we have a lot of information on our Scholl website if you want to look about any of these articles, but I won't take time. Now, ensure your wishes will be honored. Talk about end-of-life issues. This is the end. And I'm sure you're saying it's about time. Thank you. Thanks again for coming, and I hope you have some questions. I'm ready. Oh, no, I don't want to do that. Stop share.
Thank you, Betty. Does anyone have any questions? By the way, I wish it could have gone on. It's a very rich area, but we are limited to an hour. I'm going to my full screen here.
It looks like Leslie has a question. If you could unmute yourself, Leslie.
I don't know if I unmuted myself. Can you hear me?
Yes, perfect. Good job.
Hi, I'm Leslie McGibbon. Hi, Sister Paula. I'm in Florida now. My question is, I'm very pro-life. I have 4 siblings, and one of the siblings was in charge of basically the power of attorney. And my mother passed away maybe 8 years ago. I understood about the post, and she had written she did not want to be in pain. So what happened was the doctor said to my sister, she's in a lot of pain, isn't she? And then he gave her extra amount of morphine and she died. And it was like she's wincing with pain, isn't she? So just as you had said, Betty, they can kind of encourage. And my question to you is, it's like a comment to let people know it actually happens that way very strongly. But my question to you, Betty, is do you know how anybody can say anything or do anything, maybe at that moment, I'm chiding myself that I didn't say something, but I don't know what could have been said. If my mother had signed something, she was lucid like the day before. I had a roommate who went into a hospice, and she got up and cooked herself breakfast and went in the hospice, and 2 days later, her guardian had called me and said, she died in my arms. Now, and, is there anything, in other words, she was not in a lot of pain. They just didn't know what else to do. Is there anything that that people can do other than just kind of let things happen? I guess that's my question.
Leslie, this happens so often, and I think it goes back to our families. My mom and dad, and probably yours, they never questioned a physician. I mean, the physician was up here like a god, okay? And whatever the physician says, then that's what they do. These people, I almost got kicked out of nurses training because I explained to a person why they were taking a medicine, because the doctor didn't want them to know they had high blood pressure. Now that's stupid, okay? But the thing is that we don't like to question, because we feel, we are intimidated, we don't know. A doctor says she's having lots of pain. Well, people are afraid to ask, and yet we need to stand there. Like usually when I give this, I'll say, be there. You put somebody in the hospital and somebody's got to be there with them. Because this culture of death, I'm sorry to say, is very rampant, okay? And so you brought up a couple of very good examples. The only thing you can do is just confront them. And let me tell you, that was one of the hardest things I did was with my mother-in-law. and tell them. And I couldn't think of anything else to do except threaten to take her out of there. That's the only way that they finally listen to me, because that's money. Okay. And so if they're in the hospital, I just say, be there and ask questions, feel empowered, and know you're doing it because you love that person.
I'd like to say, yes, ask questions, yes, be there, be an advocate, not, yes, I go every day and have lunch with them. You know, you need to be there hours every day, you know, not just every day to have lunch. But it was more, no, it was more the, it was more the sibling thing, you know, the power, not with my mother and the doctor and what that they think, but it was more the sibling thing, like she's in charge because she's got this. So when the doctor says to my sister, I can see she's winching in pain, don't you think so? And that's what I'm saying is, you know, and I think what you hit on it, I could have taken my mother out of the hospital. Nobody would have seen, you know, I just could have said, we're going for a walk, Mom, put her in the car and gone to a wound center or something. I'm just saying that you have to defy, you have to have power. You have to defy.
Yeah.
I would have had to defy my sister who had the power of attorney. I'm just saying is.
Yeah, you can't. No, I wouldn't recommend that, because if it takes.
I know you can't legally say that, but I mean, I could have taken her for a drive, you know what I'm just saying is, and taken her to somewhere else, but anyway.
No, you really can't do that. You have to sign papers and all that if you take somebody out. But I think that that's why it's so important who you choose as your power of attorney. And if, you know, your mother had spoken with her and that's what she wanted, I would just say how you analyze the pain is another issue. And of course, like for nursing right now, talking about with everybody with mask on, you know, the usual criteria for us is sometimes changing. That's more difficult. So I'm with you. I understand. And that's why I try to do these talks because this happens too often. But you got to know, you just got to know. And I'd like to ask you if you all have your power of attorney, your power of attorney for healthcare, but I won't. Okay, just thank you very much for your question, Leslie. An excellent question. And you brought up some good points that I hadn't mentioned on. Is there another question? I was so clear there's no questions. I can't believe it. I had to cut so much out of my talk for time. I see a lot of familiar faces there. I can't believe these people are always questioning. Anne, yes. Unmute yourself and ask a question, Anne and Joe. But you're muted. I can't hear you, Anne. You're muted. Joe, unmute. Okay, now go, Anne.
Oh, I really did not have a question. I just have a comment. And
That's
that
fine.
I am enlightened by your presentation, and so happy that you had everything there in italics for us to read so that we could remember it, even take a picture of it. And it was very informative. And I just wanted to tell you, thank you. Good job.
Thanks, Anne. I needed that. But for the rest of you, I want you to know she's a hell of a good friend of mine. So that helps too. But yes, and like Dan mentioned, and I think Jacob mentioned it too, that this will be on the ILS website, that if you couldn't take pictures of the slides and you want to go there, that it's there, okay? And you can look at it. And like I think Jacob said, about a week. I think sometimes I've seen a couple of weeks. But also it hooks you to the Scholl website, which has my number on it. So if you have questions particularly, and you don't happen to have my number, you can get it that way. Okay, so that, and I'm always glad to give you any encouragement and help. I just think the human dignity, the respect for human life. When I had abortion come in 1973, I said to one of the doctors, I'll bet we'll have physician-assisted suicide in 20 years. Well, it took about 10. There's something about the dignity of a human being. There's a whole question about, most of you are working with pregnancy centers, so I know that you agree with that. But I think it just, the respect for the human entity is just, we're losing it. in some cases. And I think that's what Pope Benedict said. And we see it, certainly Pope Francis is trying to respect all people, whether they're immigrants or anyway. Okay, so thanks. Yes, Caroline, unmute yourself.
I just had one comment or a story, and that is about the importance of explaining to people what hospice care is and is not. I have a friend who had, or whose husband had Lewy body syndrome, Lewy body dementia, and he was getting worse and worse. And she finally had to put him in a board and care home because she was not physically capable of helping him any longer. And then she finally called in hospice at I'm not sure whether it was hospice or palliative care, but the director of the board and care home said, don't do that because every time somebody calls in hospice, the person dies. So it's kind of like putting guilt on her. I mean, you call in hospice because the person is going to die anyway. So I think it's really important that people understand that it's not hospice that causes people to die.
Not hospice that causes people to die. But if I have given these talks at several times, and I know Sister Paul has been there, and we've heard people come up and say that, that they did die. And one of the things that just crossed my desk yesterday, it was from Ron Panzer. I don't know, many of you might know him with the Sanctity of Human Life Month. And, Canada just recently made physician-assisted suicide within the last few years. And then they've jumped already to euthanasia, okay, that they're providing euthanasia. And now what's happening is that hospices that now refuse to perform euthanasia are defunded. They're no longer able to be reimbursed for any hospice services. They call them deplatformed. It's just kind of scary the way it progresses, and so fast. I don't know. Anyway, I think sometimes, I guess as I'm getting older, what I used to think was very old isn't very old anymore. And the respect for us seniors is, it's taking its toll. But thank you, Carolyn, for your comment. Yes. But there are very hospices out there. That's why you need questions. Yes, Joan.
Hi, sorry, I couldn't rename myself. You'd already started, so I'm Joan under the iPad. How do you check if your insurance has that physician-assisted suicide when you're recommending maybe changing? I mean, will they tell you outright, or is it in the policy, the supplemental?
Probably not, but I don't say much about insurances because honestly, Joan, I don't know that much about it. Maybe Carolyn does. But I don't have a problem asking my provider, do you believe in, they don't need to know my position, but I just, what do you think about physician-assisted suicide? And that's what I would do.
So you're saying start with your doctor first and then.
Right, with your primary.
Yeah. Okay, thank you.
Yeah, because some organizations, and now I've worked with healthcare organizations on bioethics committee, and there are doctors in these organizations, some that are really gung-ho about this physician-assisted, everybody has a right to it and all that. And there's other doctors that won't have any part of it. And so it depends upon your primary care. With that being said, once you get into the hospital, it's a hospitalist now, because your primary care doesn't necessarily go, well, probably won't go the way that things are going. So that's why it's so important that you have an advocate there that says what you want, what your goals are. But I'd say if your physician approves of physician-assisted suicide, even though I said I didn't want it, I would be kind of leery.
Okay, thank you, Betty.
That's just my personal opinion, Joan.
Thank you.
You're welcome. Thanks for the question. I love these questions.
And it was a great presentation, even though I've heard it before. It's always got new things for me to know.
Well, and we forget some things, Joan. At least I do. Yeah, at least I do. Okay, thank you guys so much. Everybody, thank you for coming and participating. It's nice. I said to Jacob, what if nobody shows up? Or nobody asks a question? And
Betty, how do we get in touch with you just with a specific question we might have?
like I said, I was going to put my thing, but I didn't. If you go to the ILS website, they have Scholl website on there, Scholl Bioethics, or just go Google Scholl Institute of Bioethics, Scholl Institute of Bioethics. And then there's a phone number up there. Okay, and
Thank you. Thank you. Okay, I got to move on.
or
Bye-bye.
email. Yeah, okay, bye-bye. Thanks for coming, Leslie.
Yeah.
Okay. I think my time is up, Dan.
Okay, well, thank you very much, Betty, for your presentation. I concur with those who commented on its excellence. It was quite good, and it's quite a rich subject. So, having heard Betty's presentation, now I'm going to tell you about our next presentation, and that's going to be on the first Wednesday of the month. So in March, that's March 3rd. And we're having a part 2 this time. In October, we had Louisa DePoe, who's from Texas, I believe the Archdiocese of Boston, who gave a presentation on transgender issues. And she's going to be doing a second part of that presentation. And so again, that's on March 3rd. So I hope all of you can join us, and if you have others, if you have friends that might be interested, it also is a very rich and fascinating subject. If there's others that you know of who might be interested, I encourage you to invite them. And then finally, I'll offer a brief closing prayer. Lord, we ask that we use in a way that is pleasing to you what we have learned today from Betty, and that it be conducive to our salvation. Amen.